Hello, today's discussion will be on respiratory distress in newborn. This is common clinical problem and can be due to variety of causes. So first I'll discuss the different causes starting from nose till the alveoli, the different causes leading to respiratory distress in the newborn, and then subsequently I'll talk on transient tachypnea of the newborn. Let's see the different causes of respiratory distress starting from above downwards, that is from the nose going down towards the alveoli. All causes of respiratory distress will present with tachypnea, that is increased respiratory rate. There can be nasal flaring, grunting, intercostal retraction and cyanosis also. So starting with the airway obstruction, can be in the nose. In the nasal, if there is a choanal atresia, nasal edema, this can lead to respiratory distress. Oral cavity, macroglossia, that is a large tongue, micrognathia, that is receding chin, glossoptosis, that is falling back of the tongue. Then laryngeal obstructions like laryngeal web, subglottic stenosis of larynx, laryngomalacia and cord paralysis. This is vocal cord paralysis. Then in the neck obstruction due to cystic hygroma and congenital goiter. And in the tracheal obstruction can be due to tracheomalacia, tracheoesophageal fistula, tracheal stenosis. So all these topics I'll discuss in detail in different lecture classes. And now come to the lung causes. In the lungs, it can be aspiration syndrome, that is mainly meconium aspiration syndrome, respiratory distress syndrome, hyaline membrane disease, which occurs due to deficiency of surfactant, and then transient tachypnea of the newborn. This topic we are going to discuss today. And pneumonia, that is inflammation of the lung parenchyma, pleural effusion can occur, pulmonary hemorrhage, air leak syndromes like pneumothorax, pneumomediastinum, and lower emphysema. So all these can be parenchymal or lung causes for respiratory distress in the newborn. And there are certain developmental defects which leads to respiratory distress: agenesis of the lung, hypoplasia of the lung, diaphragmatic hernia, tracheal agenesis and tracheoesophageal fistula. So these are all anatomical defects, developmental defects leading to respiratory distress. And now come to extrapulmonary cause. So besides pulmonary, there are certain extrapulmonary cause also which leads to respiratory distress. It can be perinatal asphyxia or birth asphyxia, congestive cardiac failure, metabolic acidosis, persistent pulmonary hypertension and phrenic nerve paralysis. So all these can lead to respiratory distress. Okay, now I'll talk shortly on transient tachypnea of the newborn. So what this is? This is a benign self-limiting cause of respiratory distress in term or near-term newborns, and this occurs due to delayed clearance of the total lung fluid. Occasionally, this is also called respiratory distress syndrome type 2. Respiratory distress syndrome type 1 is hyaline membrane disease, which is occurring due to deficiency of surfactant. And this is a mild and self-limiting cause that I already said. And then is very commonly seen or more commonly seen in the cesarean section deliveries. The very distinct feature of this condition is sudden recovery of the infant. The distress is so much and suddenly the child recovers. So if this happens, then you have to think of transient tachypnea of the newborn. So before categorizing a child as a transient tachypnea of the newborn, you have to rule out all the other pathological conditions of the lung. Then only you can say this is a transient tachypnea of the newborn. Why this occurs? Pathogenesis. So this condition is due to slow absorption of fetal lung fluid from pulmonary lymphatic system, resulting in decreased pulmonary compliance and tidal volume. So this decreased compliance leads to respiratory distress. So to understand this, you have to know why it is more commonly seen in cesarean section and not in normal deliveries. Normal deliveries, when there is a labor pain, there is excess secretion of catecholamines, and these catecholamines activate epithelial sodium channel, also termed as ENAC, and this channel will absorb the excess fluid from the lungs. So this is happening in the normal labor due to the labor pain, whereas in the cesarean section delivery, or if the delivery is occurring very fast, precipitated deliveries, so in these conditions that pain is not there to stimulate the excess secretion of catecholamine. So in the cesarean deliveries, level of catecholamine is remaining low, so there is less activation of this epithelial sodium channel, hence delayed absorption of the lung fluid, leading to respiratory distress. So now come to the risk factors. What are the risk factors for this condition? There are maternal risk factors and fetal risk factors. Maternal risk factors are cesarean section deliveries without any labor pain, rapid vaginal deliveries, infant of diabetic mother, and in the fetal, male child are more prone to have this condition, perinatal asphyxia, late preterms, that is 34 to 37 weeks of gestation, small for gestation age and large for gestation age. Babies are at more risk to have this condition. Now, clinical manifestations, how a baby presents. So, onset is within 1 to 2 hours of birth. Baby presents with a tachypnea, that is increased respiratory rate, and for newborns, more than 60 is considered as tachypnea or increased respiratory rate. There is no or very mild retractions, mild cyanosis which is relieved by minimal oxygen of less than 40%. There can be mild expiratory grunting, and recovery is rapid. So rapidly, suddenly the child improves within 24 hours to 3 days of life, and lungs are generally clear without any rhonchies on auscultation. When you do a X-ray, this is the X-ray of a transient tachypnea of the newborn baby. There is a prominent pulmonary vascular markings in the X-ray. You can see fluid line in the interlobar fissures. Sometimes in this it's not very clear, but sometimes you can see fluid very faintly. You can see at this side. So there can be interlobar fluid in the fissures, interlobar fissures. There can be fluids. Or there is over aeration of the lung field. There is prolonged with a flat diaphragm, and occasionally there can be pleural fluid also. So to distinguish this condition from hyaline membrane disease, which is respiratory distress syndrome 1, is sometimes difficult. But in hyaline membrane disease, there is reticular granular pattern with the air bronchogram is seen in X-ray, but in transient tachypnea of the newborn, this finding is absent. There is no reticular granular pattern or air bronchogram in the X-ray. Coming to treatment, there is no specific treatment. Treatment is just general supportive measures you can take. You can give initially oxygen via hood or the nasal prongs, where minimum oxygen is required, and then intravenous fluid can be started since child is having tachypnea, and then suddenly it subsides on its own within 24 to 72 hours of the life. So the prognosis of this condition is excellent and good, and there are no sequelae after this recovery. So many times after excluding all the causes, it can be the cause for respiratory distress can be transient tachypnea of the newborn. Okay, thank you. Next class I'll come with the other causes of the respiratory distress in the newborn. If you find my class helpful, please like and subscribe so you will not miss the next lecture. Thank you.